Welcome. We're going to just wait a couple minutes for more participants to join, and then we'll get started with our grand rounds. Thank you for joining. Okay. Welcome, everyone. Thank you for joining the Harvard University Center for AIDS Research Grand Rounds on the theme of cardiovascular disease prevention in people with HIV. My name is Markella Zanni. I'm an associate professor of medicine at Harvard Medical School and associate chief of the metabolism unit at Massachusetts General Hospital. I'll be introducing our speakers today, and then after the two speakers have shared their insights, we're going to have a discussion which I'll be moderating. You may enter your questions into the chat, and we will aim to address those questions during the moderated Q&A at the end of the two presentations. Our first speaker today is Dr. Virginia Triant. Dr. Triant is a clinician and clinical investigator in the infectious diseases and general internal medicine divisions at MGH, dedicated to studying the long-term non-communicable complications of HIV infection. The focus of Dr. Triant's research has been on the intersection between HIV, cardiovascular disease, and non-communicable chronic disease complications. She's investigated rates and determinants of clinical outcomes such as myocardial infarction, stroke, and fracture in people with HIV, and is currently investigating optimal cardiovascular disease risk prediction strategies in people with HIV and people with HIV and Hep C. Dr. Triant is an active infectious diseases clinician, maintaining an outpatient clinic and attending on the infectious disease consult service at MGH. Through research, clinical care, and mentoring activities, she brings a cross-disciplinary approach to clinical outcomes research with the goal of improving long-term outcomes and enhancing the care and well-being of vulnerable populations. Thank you very much, Dr. Triant.
Well, thank you so much, Dr. Zanni, for the introduction. I'm going to go ahead and share my screen. Well, it's a pleasure to be here today to present on cardiovascular disease prevention in people with HIV, the past, present, and future. So I have no disclosures. So in this section of the talk, I will lead off to present a backdrop or a foundation of the field of cardiovascular prevention in people with HIV. So my focus will be to give a brief overview of the landscape of the epidemiology of our current understanding of mechanism, and an introduction to the field of cardiovascular risk prediction or estimation in people with HIV to set the stage, and then we'll pass the baton over to hear the rest of the talk about Reprieve. So we'll start to give a brief overview of the epidemiology of cardiovascular disease in people who are living with HIV. So as many and most in this audience are familiar, the population of people living with HIV is aging as a whole. And as this population ages, the group is facing increased rates of chronic disease complications. What we can see from this slide is a slide depicting age-related chronic disease complications, comparing people with HIV, living with HIV, to those living without HIV. And what you can see for this set of chronic disease complications is for each given age group, people living with HIV have a higher number of chronic disease complications compared to those who are not living with HIV. So salient among these complications is cardiovascular disease or acute myocardial infarction. This is a depiction of many of the studies over time, which has formed the basis of our understanding of cardiovascular disease in people living with HIV. And what you can see from the column and the effect size on the right side is that across cohorts and over time, people with HIV have about a 1.5 to 2-fold increased risk of myocardial infarction compared to those who are not living with HIV. And this effect has been fairly persistent across multiple studies. This is an overview of a meta-analysis that was performed that encompassed 73 studies, 122 estimates, and almost 800,000 people living with HIV. And what this shows is, again, consistent with the prior slide, about a 2-fold increased risk of cardiovascular disease conferred by HIV and independent of traditional risk factors. So you can see the red sort of elongated triangle or elongated diamond at the bottom that shows a risk ratio of 2.16. And this was fairly consistent across all cardiovascular disease, and then when specifying for either MI or stroke as individual outcomes. And what this has really shown us is that HIV can be considered to be itself a cardiovascular risk factor. And this is actually a comparison of the risk from the prior meta-analysis compared to standard risks attributable to traditional cardiovascular risk factors. And what you can see is that the effect size for HIV on the bottom is fairly comparable to long-standing, established, robust cardiovascular risk factors in the general population. So let's shift a little bit to talk about the mechanism and the pathophysiology. So why are we seeing this increased risk of cardiovascular disease in people living with HIV? Well, current understanding suggests that the mechanism is multifactorial, spanning what we can see here. So traditional cardiovascular risk factors, HIV-specific factors, in addition to genetic and lifestyle factors. And delving in a little bit deeper, in terms of traditional risk factors, multiple studies over time have showed traditional risk factors to be enriched and occur at elevated rates in people with HIV, particularly smoking, which is seeing quite high lifetime rates and rates across cohorts. There's also a wealth of data looking at the effects of antiretroviral medications on cardiovascular outcomes. And I'll only briefly summarize in this talk in the interest of time, but there have been effects of protease inhibitors, particularly older protease inhibitors, whose cumulative use has been linked to increased myocardial infarction risk. There has been consistent but somewhat conflicting data on the effect of the NRTI abacavir on myocardial infarction risk over time. And more recently, there has been data linking the newest and most widely used class of antiretroviral medications, integrase inhibitors, to weight gain, but not yet consistent or really long-term data accrued enough to suggest that weight gain has translated into cardiometabolic outcomes or events. So, considering these two factors, we might think that the effect of traditional cardiovascular risk factors and the effect of antiretroviral medications, both individually and by class, together could in fact explain this approximately 2-fold increased risk that we're seeing. Yet, across multiple analyses that have accounted for traditional risk factors and the potential impact of medications, we see that cardiovascular risk still persists among people with HIV, suggesting that there's an unaccounted for risk factor not explained by traditional risk factors and medications. And this additional component that has been driving the risk is thought to be HIV-specific inflammation and immune activation. So interest in the hypothesis that inflammation might drive the excess cardiovascular risk observed in HIV was really sparked by the SMART study. This was a study back in 2006 of treatment interruption versus continuous treatment with a primary endpoint of recurrent opportunistic infection or death. And what this showed was that increased cardiovascular disease event rates were observed in the drug conservation group, so the episodic treatment group. So if we were hypothesizing that antiretroviral medications were the culprit conferring cardiovascular risk, one would suspect that the continuous and longer term group would experience higher event rates. In fact, the opposite was true, that the group that interrupted treatment had higher event rates, and there was a concomitant increase in the inflammatory markers IL-6 and D-dimer that coincided with the increase in HIV RNA a month following treatment interruption. So fast forward almost a decade later to the START study. This was a study assessing rates of events by early versus deferred ART initiation. And what this showed was that earlier treatment reduced serious illness or death overall by approximately 50%. Now, as anticipated, earlier treatment reduced AIDS-related events with a robust 70% risk reduction. But interestingly, earlier treatment before individuals reached a level of a lower CD4 count and more pronounced immune dysfunction, there was still a 33% risk reduction for non-AIDS chronic disease events. And this suggested that early ART is likely beneficial, not only from the perspective of reducing AIDS-related events, but also from the perspective of reducing non-AIDS events and cardiovascular risk, thought to be by reducing inflammation and immune activation. I won't go in detail into the studies here, but multiple studies over time have linked specific inflammatory and immune biomarkers to varying indices of cardiovascular risk, to plaque, to surrogate markers of cardiovascular disease. And this image depicts the many pathways which are potentially implicated in cardiovascular risk in HIV, and which may be targets for intervention. And so the clinical correlates of inflammation and immune activation that we measure every day in clinic, or of course CD4 and viral load, or HIV and RNA, these two have been shown to be related to cardiovascular risk. So this was a study out of the VA that showed increased HIV RNA and decreased CD4 less than 100, each to be independently associated with increased MI risk. What's notable in this study is even for people who are virally suppressed and even for people who are immune reconstituted with a higher CD4 count, there's still a persistent risk of approximately 40%. So even in this group of treated individuals living with HIV, there's still a persistent risk that, again, is thought to be attributable to HIV-specific inflammation. So moving on to risk estimation. So we're going to move into the clinical implications of this increased risk. Cardiovascular risk prediction algorithms combine risk factors to predict the 10-year risk of developing cardiovascular disease. Yet it has been hypothesized, and now studies have shown, that cardiovascular risk prediction algorithms may not be accurate in the setting of HIV because they incorporate only traditional risk factors and do not incorporate HIV-related factors. Existing cardiovascular risk prediction scores have actually been shown to underestimate risk in people living with HIV. In data out of MGB here in our cohort, we've demonstrated underestimation of risk across the board, and particularly among women and among those with low or moderate predicted cardiovascular risk. We've also, other studies, including the CENIX cohort and the HOPS and Athena cohort, have similarly demonstrated underestimation of risk. And we'll go in the next section of the talk into further data on risk prediction. So these are data out of our MGB HIV cohort. This is a large cohort comprising all of the data at MGB, a clinical care observational cohort. And what we found when we validated existing risk scores in this cohort of people living with HIV was that discrimination, or the ability to distinguish people with and without the outcome, was reasonable, was moderate. But the calibration, which is the agreement between observed and predicted risk, was actually poor. So what this shows is the deciles of predicted risk, comparing predicted risk in blue to actual observed risk in red. And we see that for most deciles of predicted risk, the observed risk is greater across the board. We also found in this study that the underestimation of risk was relatively greater among women, and was also relatively greater among lower or moderate cardiovascular risk groups. So these are groups where the clinical decision-making really remains uncertain, and consideration of interventions might be influenced by calculation of the risk score. Over time, over time, there's been increasing recognition of cardiovascular risk in people living with HIV. And I'll sort of walk through the evolution of understanding, and then talk about what's notable is that until very recently, we really haven't had trial data or guidelines to actually inform our clinical care. So over the decades, there's been a wealth of understanding of epidemiology and mechanism, yet relatively little of that has translated yet into HIV-specific guidelines. So in 2018, there was an update to the 2013 ACC/AHA cholesterol guidelines, and this included HIV as an ASCVD risk enhancer. So recognizing the fact that HIV does confer this increased cardiovascular risk, and this was included in the guideline and suggested that this should be considered a risk, not per se a risk factor, but a risk enhancer. The following year, the ACC/AHA released a special report that considered, again, HIV as a CVD risk enhancing factor, and it highlighted that the pooled cohorts equations, or the ACC/AHA ASCVD risk equation, tends to underpredict risk in this group. Clinician-patient discussion was suggested to determine whether individuals should be reclassified, but again, there was no specific guidance, clinical guidance, in terms of what we should actually be doing in clinic to acknowledge and sort of incorporate this risk into our clinical prevention strategies and care. That same year, the AHA released a scientific statement on cardiovascular risk in HIV. And this took it one step further beyond HIV itself as a risk enhancing factor, but included HIV-related cardiovascular risk enhancing factors. So even within people living with HIV, there are factors that could further sort of up titrate or down titrate the risk. So factors including prolonged viremia, ART initiation delay, low CD4 count, metabolic syndrome, and hepatitis C were considered to further heighten the cardiovascular risk, even within people with HIV who were already at heightened risk. And this provided the closest we had come at this point to specific clinical guidance for people living with HIV with regards to cardiovascular disease. And it suggested calculating a risk score and then considering adjusting the risk upward or up titrating the risk to reflect the fact that our current algorithms have been shown to underestimate risk. So despite clear progress in the recognition of people with HIV as an at-risk group for cardiovascular disease and an enhanced understanding of the mechanism, to date, prior to Reprieve, there had been no HIV-specific guidance and really no trial-level data to inform our understanding of how we translate the epidemiology and mechanism into clinical care. The recommendation was had always been to use the general population guidelines, but on many levels, the general population guidelines are not fully accurate and inadequate for people living with HIV. And I think when we look at possible interventions for cardiovascular disease, as you can see here, there are interventions that may target traditional risk factors and interventions that may target novel risk factors or inflammatory and immune factors. But there was no intervention at that point that could target both and could really address sort of both pathways, the traditional and the HIV specific or non-traditional, which result in this increased risk. So I'll give a little bit of summary as we segue to the next talk, and sort of where we're at in terms of background. Hopefully I've shown you that there had been and still remains a critical need to tailor cardiovascular prevention strategies to people living with HIV. There are currently disparities in cardiovascular risk prediction and in prevention for people with HIV, as our clinical paradigms have not reflected our mechanistic understanding. Current recommended clinical strategies for cardiovascular risk estimation, including considering HIV as a risk enhancer at minimum, building cardiovascular risk assessment into practice, managing traditional cardiovascular risk factors aggressively, considering underlying cardiovascular risk and cardiometabolic effects when selecting specific antiretroviral regimens, and now recommending statins based on the Reprieve results in the new HHS guidelines, which we'll be discussing in detail in the next section. And I always like to highlight that really the care we provide and the intensity of the engagement in care for people living with HIV provide an opportunity not only to optimize HIV disease, but also to optimize health overall and prevent chronic disease in people with HIV. So I'll stop here and I'll turn it over to Steve. Thank you.
Great. Thank you so much, Dr. Tryon. There's one question in the chat, but we're going to pull all the questions to the end of the presentation. So right now I'll go ahead and introduce Dr. Grinspoon, who will be our next speaker. Dr. Stephen Grinspoon is a professor of medicine at Harvard Medical School and chief of the metabolism unit at MGH, as well as director of the Nutrition Obesity Research Center at Harvard. He's had a long-standing interest in metabolic and immune complications of HIV disease. He chaired the American Heart Association State of the Science Conference on Cardiovascular Disease in People with HIV, and his work has suggested significant cardiovascular disease risk in people with HIV and highlighted the relative contributions of traditional risk factors and non-traditional risk factors, including using novel PET and CT techniques. He is the principal investigator of the International Randomized Trial to Prevent Vascular Events in HIV, or REPREVE. And in addition, he has shown efficacy of strategies to improve ectopic adipose tissue deposition, leading to the development of an FDA-approved strategy for visceral fat reduction among people with HIV. Dr. Grinspoon?
Hey, thanks very much, Markella. I hope you can hear me and see these slides. Thank you, Jean, for a really informative talk, and thank you to the CFAR for the invitation to speak today. I am going to pick up where Jean left off and tell you a little bit about the REPREVE study, and talk to you about some of the data in that regard, and then also segue into optimizing future strategies based on what we've learned in REPREVE. These are my disclosures and funding. So there are a number of current challenges in preventing cardiovascular disease in HIV. As Jean outlined, identifying patients with subclinical disease is often difficult. The current risk identification strategies are really not adequate, need to be recalibrated, and may need to have HIV-specific information added. We need to develop an intervention that addresses, as Jean nicely outlined, traditional and immune-related risk factors, i.e. that reduce inflammation. And if you reduce inflammation too much, this can increase the risk of infection. So it's very difficult to thread the needle here and to consider a strategy which may do both safely. We also, as I just mentioned, need to develop a strategy that is overall safe and effective. So why did we do REPREVE? What was our rationale for that? We hypothesized that a statin strategy would prevent cardiovascular disease, even in people with HIV with a low to moderate traditional risk. And that's really important because this is a group that's not often targeted, but these people do have cardiovascular disease with HIV, so it's important to consider that. And also that we would have a pleiotropic effects beyond LDL lowering with statin therapy, which would address the unique phenotype of inflamed, low attenuation, vulnerable plaque. And this was really a unique design in that all the prior primary prevention trials have focused on populations with higher baseline traditional risk. And it's never been attempted to address a primary prevention in a group of patients with relatively low to moderate baseline traditional risk. And that was our task in REPREVE. And over on the right, you can see the specific phenotype of cardiovascular disease in this population with low attenuation fatty plaque, which is vulnerable to disruption, and also inflamed endothelial surfaces as assessed by FDG PET in people with HIV. So these prior studies have suggested that we need a pleiotropic strategy in this regard. So how do statins work, and how may they uniquely target excess immune activation in people with HIV? So we all know that statins reduce lipid levels, and that's why they were approved and have been probably the best-selling drug in the history of medicine. But they also have other effects, including reducing lipid oxidation and NLRP3 inflammasome, potentially also to affect plaque inflammation. And they also reduce indices of monocyte and T cell activation. And some of these effects, i.e. through mid-88, are shown here on the left affecting the inflammasome, and on the right, affecting soluble CD14, which is a marker of monocyte activation. So we knew this coming into REPRIEVE, that there might be a pleiotropic effects of statins, and we hope to harness that effect through the trial. So we launched REPRIEVE in 2015, and this was, a collaboration between multiple institutes at NIH, the AIDS Clinical Trial Group, over 110 sites, including sites here at Harvard, and then also through funds provided by industry, including Kowa, Gilead, and ViiV. The participants were enrolled in 11 countries: United States, Canada, Spain, Thailand, Brazil, South Africa, Zimbabwe, Uganda, etc., even Sub-Saharan Africa, Botswana, Peru, India, and the Asian continent, and also Haiti. We recruited patients starting in 2015, as I mentioned, and we closed the trial in 2019 after recruiting 7,769 participants. These participants were all asymptomatic without a known history of cardiovascular disease with low to moderate ASCVD risk, as mentioned. And we ran the trial over a period of time. In this case, it was approximately 5 years. And our primary endpoint was MACE, major adverse cardiovascular event, which was included cardiovascular death, MI, unstable angina, TIA or stroke, arterial revascularization, or peripheral artery disease. We had a number of secondary endpoints as well, which I'll get into later. But embedded within REPRIEVE was a mechanistic substudy enrolling 805 of the 7,769 participants for serial CT angiography to follow up on that observation we had made in cross-sectional studies to see if we could reduce that non-calcified fatty vulnerable plaque. So our study population, the inclusion and exclusion criteria shown here, documented HIV unstable ART, CD4 more than 100, age between 40 and 75, primarily because the risk score is not known to be calculated in people lower than that or higher than that age based on current algorithms. No known history of ASCVD, and a 10-year ASCVD risk score, which was dependent on your LDL. So we allow patients into the trial whose ASCVD risk score was less than 7.5 if they could have an LDL less than 190. We allow people in between 7.5 and 10 if the LDL was less than 160, and we allow people in with an ASCVD risk score between 10 and 15 if the LDL was less than 130. So you can see that as the risk score went up, we required a lower LDL score. We excluded patients who are currently using statins, gemfibrozol, PCSK9 inhibitors, or who had decompensated cirrhosis. So in general, it was kind of a lower risk, low to moderate risk population between 40 to 75. These are the primary results which have been published and now updated in a second New England Journal paper. The effect on the primary endpoint of first primary MACE was a 35% reduction versus placebo. It was a very, very significant result and a very strong result compared to the effects of other strategies to reduce cardiovascular disease. The secondary endpoint of first MACE or death was also significantly reduced by 21%. To remind you, the participants were age 50, so relatively young. The median ASCVD risk was only 4.5%, and the median LDL was only 108. This is not really a population that you would probably, before REPRIEVE, rush to put on statins, and that was the whole point of REPRIEVE, to try and inform us whether we should do that or not. So this is another slide showing the effects, the 36% reduction. This is the updated final data set. We had another endpoint, which was a secondary endpoint called hard MACE, and this is myocardial infarction, stroke, or cardiovascular death. And the effect on hard MACE was even stronger. So it's a hazard ratio of 0.59. You can see when we looked at the individual components of MACE that they were very consistent. There's a very consistent effect across all these endpoints. Also, you could look to see the types of endpoints that we had in the trial. And we had, interestingly, a fairly large number of strokes as well as MIs in about equal numbers of each. And happily, the effect size was significant, really, on both of those major components of MACE. When we looked at effects on key subgroups, here's the overall effect. You can see a very similar effect on females and males. And I might add that we recruited over 30% of the study population were females. So we were proud of that, and we had some power to make some observations in that group. In addition, there was very little difference whether your LDL was high or low at baseline. So the treatment effect was independent of LDL. So this is really an important observation. And in general, so there was also consistent effects across race and GBD region. You can just get a sense if you look down here that it was generally consistent effects. There was no treatment modification based on CD4, nadir CD4, HIV, RNA, or ART duration. Now, in terms of additional findings, more than 80% in both groups remained in follow-up, which is quite amazing after 5 years in which the treatment arm, that drug was available by prescription to anyone. So we had 80% adherence in both groups, which is great. The LDL was reduced just as expected by about 30%. You can see the purple versus the green violin plots shown here. And the placebo group remained quite consistent over time. All MACE events were adjudicated vis-a-vis COVID, and in fact, only one event was definitely related to COVID. So our results were not influenced by the COVID pandemic that we had faced through the trial. In terms of safety, the DSMB concluded that there were no unanticipated safety concerns. Only 1% versus 0.5% withdrew for muscle-related symptomatology. The diabetes rates were increased, but in both groups, but a little bit more in the pitavastatin group, 5.3% versus 4%. And this is entirely consistent with other studies. The protective effect of statin therapy was seen even in the group with diabetes. So there was a 50% reduction in MACE even among diabetics in the pitavastatin versus placebo groups. This is very important to note. There was no effect on grade 3 ALT or rhabdomyolysis. Now, we looked at the results in many different ways, but here's one way of looking at them. This is a nomogram, if you will, displaying the mean LDL difference between treatment arms in various large statin trials versus the efficacy and reduction of cardiovascular events. And you can see that along this nomogram, if we plot REPRIEVE in the dotted green line, there was a 0.8 millimole difference, 30 milligrams per deciliter in LDL cholesterol. And if you go up to the line, regression line, and go over, that would have resulted in a predicted 17% reduction of events, but we were up at 35, 36%. So there's a significant additional efficacy. So there was a much larger effect than one would have predicted based on the reduction of LDL alone. So LDL matters, but the statin effect is beyond that. And we had a hint of that a little bit at baseline because the baseline LDL was irrelevant to the effect of statin therapy. Now, we often talk about number needed to treat in large trials, and the number needed to treat overall and the updated final data was 100, which is actually pretty good for a large primary prevention trial, particularly among young people, younger people who don't have the largest predicted risk to begin with. As the predicted risk goes up, the number needed to treat goes down. You can see that very, very nicely here. And in the group between 5 to 10% predicted 10-year risk, it's only 53. And in those more than 10, it's only 34. It's not even bad among the group between 2.5 and 5. So this is very useful. And the DHHS and AHA and European AIDS consortiums took these data into account when they dealt with guidelines. So that brings us to the guidelines discussion, and Jean outlined that very, very well. This cartoon here is the algorithm for treatment of ASCVD risk with statin therapy and other strategies globally by the AHA. And you can see that, of course, if someone has a very high risk, more than 20%, statins are indicated, or also if you have an event, then it's secondary prevention. But in this other red box, there was really disagreement and confusion about what to do. The guidelines recommended consideration and discussion at intermediate risk and more of a discussion without initiation at lower risk. But it was all kind of a little bit hand waving. As Jean mentioned, they did add in 2019 that HIV was a risk enhancer, but they didn't make a conclusion about who actually should get statins. And based on REPRIEVE, we're very happy to report that the DHHS, AHA, European AIDS, and British HIV Association have changed the guidelines, and they all changed it in about the same way. And there is now an A1 recommendation for pitavastatin in people with HIV who have more than a 5% risk. So anyone in this box over is recommended. And pitava is the first treatment recommended, but they took it as a class effect, if you will, even though we only studied pitavastatin. The likelihood is strong of a class effect. So they recommended that if pitavastatin wasn't available, rosuvastatin or atorvastatin could be recommended at these doses. They even went so far as making a C1 recommendation for those less than 5% in this column over here. And that recommendation was less strong because the number needed to treat is higher. And they recommended a discussion, but that consideration could be given for statin, and it would not be wrong based on our results. So that's important, and these are the new guidelines. You can click on the QR code and look at them. If you think about it, because people with HIV and anyone would risk would increase with aging year on year, eventually everyone over here is going to come over to here. And so it's just a matter of, what your baseline risk. If you're at 4.5, you're going to come over very quickly. And in a minute, I'm going to get to the underprediction issue that Jean raised, which adds another little detail to this. But since everyone is going to age into the higher risk category eventually, some clinicians are putting people on early, others are waiting. There's no right or wrong in that regard, but there is a strong recommendation that when you cross 5% based on REPRIEVE, you be prescribed a statin for primary cardiovascular prevention. So let's talk about the performance of these risk prediction algorithms. And Jean really nicely outlined this. So now we're looking at REPRIEVE in the data in the placebo group, and we're trying to see how well the risk prediction equation did in reality. And this is one of the first prospectively performed assessments of the pooled cohort equation ever done. And as she mentioned, and consistent with MGB data, the overall discrimination was reasonable. In terms of the underprediction, overprediction issue, overall, if you just took a mile-high view, the study did pretty well. There were 84 observed and 81 expected for an ODE ratio of 1.03. But the plot gets thicker if you look at subgroups, particularly women and particularly in high-income regions. So you can see here on the right that when the dots are above the line, there's more observed than expected, so there's underprediction. You can see there's underprediction in high-income regions compared to non-high-income, and that this is particularly severe for Blacks and for women. Very significant underprediction for women. Very, very consistent with prior papers. And then we had the opportunity, which this has not been published yet, but to recalibrate this. And, we're probably going to come out with a recommendation of approximately 2.8 multiplication factor to apply to females, and particularly Black females, a little lower for white females, in terms of how you would use this algorithm. So you might, if someone had a risk of 2.5, a Black woman, then maybe that's really a risk of like over 5, and that might influence your decision because it's crossing the 5% threshold. And we can talk more about this in the discussion, but it's really nice to be able to apply these data to the DHHS guidelines based on the results of REPRIEVE. Now, Markella has led another aspect of this in which she's looked at modifiable risk factors on first MACE. So this is taking the whole cohort, and this is controlling for statin use. It's asking which of these things are related to the future development of a MACE event. And so you can see here that anything, and by the way, the blue is an adjusted value for all these other factors, and the pink is unadjusted. But you can see here that there's a strong effect of age. As you get older, there's a much larger effect on MACE. You can see here that after adjustment, female sex was no longer protective of MACE. This is in contrast to the general population, in which female sex is typically protective of MACE. This is a major observation. This lack of an effect is a major observation, and that Markella is working on, and that's her area of expertise. But it's really, really interesting, and it's also suggests it may be important to apply that calibration factor. There were differences in GBD region, particularly certain regions had lower risk, including sub-Saharan Africa, compared to high-income areas. This is also seen in Southeast and East Asia. Smoking was definitely associated with future risk, as was hypertension. Really, there wasn't much of an effect on BMI, interestingly, after adjustment, nor glucose, et cetera. There was an effect of lower of HDL to be protective, as you could imagine, et cetera. And there was a hint that the higher your nadir CD4, the more protected you were. So a lower nadir CD4 was dangerous. And that's consistent with a lot of other observations, so it wasn't statistically significant. What was statistically significant, however, was that even in this study when everyone was on ART, and the vast majority had controlled viral load, I think 88% had controlled viral load, that small percentage that had detectable viral load had a much larger risk of developing cardiovascular disease in this study. And I think that's entirely consistent with prior observations, but now in a prospective trial. Now, in terms of the mechanistic sub-study, this was a sub-study looking at effects on plaque, as I mentioned, and inflammatory biomarkers. And this is an example you can see here of a non-calcified eccentric plaque, kind of a juicy, high-risk plaque that we were aiming to improve in REPRIEVE. And indeed, we just published that we did improve this. There was a significant effect to reduce non-calcified plaque volume and progression of non-calcified plaque. There was a 33% reduction in the progression of non-calcified plaque. If you look at these pie charts among patients with baseline plaque, you can see here that in the pitavastatin group, there was a lot more regression than in the placebo group, and a lot less progression than in the placebo group. So it's a really interesting confirmatory result as to our hypothesis. We looked at these inflammatory markers, and you could see significant reductions in a few of them: LPPLA2, oxidized LDL, and a modest improvement in high sensitivity CRP. So that was interesting. But what was really more interesting, I think, was the fact that the change in these did not really affect plaque. So the reduction in LPPLA2 or CRP did not affect plaque. And even the reduction in LDL or achieved LDL was not, at the end of the day after adjustment, significant, although it tended to be. So there's other things that are happening here, and we're investigating these other factors as we speak. And it's going to be a very complex situation in terms of why REPRIEVE reduced plaque as it did and why it reduced MACE, and further studies are necessary in this regard. So what other strategies might be useful? I think Jean really covered this nicely. Traditional risk modifiers based on the graph and the forest plot I showed you of what's contributing to MACE. Modification of traditional risks is really important, anti-smoking efforts. One might consider simultaneous metformin for those at risk of diabetes, i.e. with obesity or pre-diabetes, to avoid that. Antihypertension treatments might be useful, and I'll talk a little bit about that in a minute, some data we have with the eplerenone. I think our data strongly suggests that anti-obesity treatments might prevent diabetes and decrease risk of MACE, particularly for those with obesity, but that will need to be tested in a clinical trial. Then the question is whether there are other anti-inflammatory modulators, and I think the biggest anti-inflammatory modulator would be to ensure full suppression of viral load, maybe for longer, because our data suggests detectable viral load is associated with risk. And then we recently have data to suggest that there are some biomarkers related to residual risk that we'll need to study more and target in future studies. And let's talk about hypertension just as I finish here. You'll notice that there was really not a significant, less significant effect of statin therapy in REPRIEVE among those with hypertension. So that suggests that maybe that subgroup might need an additional therapy. And, we haven't tested this formally, but in a separate study, Suman Srinivasa from our group did use eplerenone, which is an antihypertensive, and showed a significant reduction in arterial inflammation. So I'm sure there'll be additional studies in the future that are taking the data from REPRIEVE and looking at additional therapies that could be added, as I've now mentioned. So in summary, cardiovascular risk is increased among people with HIV, despite younger age and only low to moderate traditional cardiovascular risk. In this group, 40 to 75 on ART with low to moderate risk and normal range LDL, treatment with a statin strategy is well tolerated, effective, and will prevent MACE with a larger risk reduction of 36% at a reasonable number needed to treat. This effect is greater than that explained from LDL reduction alone. Other strategies to reduce arterial inflammation may complement statin therapy in the future, and targeted therapies for specific risks, i.e. obesity, may also be complementary, particularly now in this age of GLP-1 agonists. So I want to thank the participants, site teams, investigators, and funders, and I'll stop there. Thank you very much for your attention.
Wonderful. Thank you so much, Dr. Grinspoon. We have a number of questions posted in the chat, so I'll read these out and I'll direct them to one, but please feel free both to comment if you would like to. Let's have the first question for Dr. Triant. The question is, do you know of differences in cardiovascular disease risk based on the age at which someone began living with HIV?
Well, thank you very much. It's a great question. I don't know specific data that relate the age of HIV diagnosis to cardiovascular risk. There are, however, data showing a relation of nadir CD4 cell count to increase cardiovascular risk. And so a lower nadir CD4 may be a proxy for duration of HIV infection, possibly age at diagnosis, with a longer duration suggestive of potentially more pronounced immune dysregulation.
Excellent. And on a related point having to do with estimating cardiovascular disease risk, there's a question, how close are we to having a risk calculator that more accurately predicts the risk of cardiovascular disease in people with HIV? Where are we with derivation and validation of a new calculator, and how will such a calculator impact our application of statin guidelines based on REPRIEVE?
Great. Well, no, thank you very much for that question. So that is actually an area of active investigation underway. So I actually have a recently funded R01 in collaboration with the REPRIEVE group here to actually answer that question. So we're going to be working in collaboration with Steve and the team and Markella around developing a new cardiovascular risk score using REPRIEVE data that incorporates not only demographics and traditional risk factors, but also HIV-related factors, and notably immune biomarkers and genetic data, polygenic risk score. So stay tuned. That's actively coming. I mean, with regards to how this is likely to impact application of the statin guidelines, As Steve gave an overview, the recently released HHS statin guidelines base the strength of a statin recommendation on thresholds determined by the PCE, or the ASCVD risk score. So as he alluded to, 5% is that threshold, so more than 5%. There's a strong A1 recommendation for a statin. Under 5%, there's a less strong C1 favoring a statin. And so in terms of this threshold, this actually reflects what we've observed with application of the ASCVD risk score and underestimation of risk in HIV. Were we to develop a new risk score, whether it be based on a current one or a new one, I think at that point we'd have to reconsider and potentially adjust these statin thresholds that are used for the strength of statin recommendation to be based on the new risk score.
Thank you. Question for both. Given that people with HIV may need to take so many medications already, what has been the general feeling among people with HIV in terms of potentially adding another medication to their regimen?
Yeah, it's a good point. I mean, luckily today, ART regimens have been greatly simplified. Some are one pill, some people take one pill a day. Now there's long-acting drugs being developed. And statins have a long history of being added to other drugs and other regimens and are very well tolerated. So I think, if it was a really complicated drug that was needed to be given multiple times a day by injection or something, that would be a different story. But since it's one pill a day, and since the HIV regimens are being simplified, I think given the risk-benefit ratio, people were adhering quite well to it in the trial, and I would hope in the real-world experience that would be the case as well. It's also very cheap.
Thank you.
I would just add briefly, certainly as people with HIV age, polypharmacy is a true concern, but I think potentially adding this medication, which has had such a robust effect, may prevent future other medications. In my clinical experience, for the most part, patients have been very receptive to adding the statin, but I think that it's certainly having a discussion and shared patient decision-making is really important in this regard.
Thank you. Another question in the chat. Are there data on statin-induced changes in immune biomarkers such as MCP1, IL-6, soluble CD14 in relation to plaque and also in relation to cardiovascular risk reduction?
Okay, I can take that one. The only biomarkers we showed to change in relation to pitavastatin were the ones I mentioned: oxidized LDL, Lp(a)2, and CRP. So the other ones, we did measure IL-6 and MCP1, did not change. But there's two separate questions. One is, at baseline, what biomarkers predict residual risk beyond statins? And then secondarily, which of them can you change? I think our data are going to ultimately show that biomarkers such as troponin, IL-6, and CRP are probably going to be very good markers of residual risk that predict risk beyond the reduction you get with statin therapy. But we have to understand other factors, and we are also doing some studies now on completely different mechanisms which may stabilize the plaque surface in terms of increasing collagen formation to make that fatty, non-calcified plaque more stable. So stay tuned, as Jean said, stay tuned for other things, and stay tuned for this too. I think it's very, very complicated, and even in the world of non-HIV, people have not delved into how statins work in a pleiotropic fashion. So we're going to hopefully shed some light on that.
And there's a question in the chat that's on a related note about forthcoming projects through Reprieve. How can Harvard CFAR investigators get involved?
Call us, call me, call Markella, look at our website. We have, I think, isn't it Markella, www.reprievetrial.org. We have a great list of projects that are ongoing. So if you like a project, let us know, and you can be part of the writing team or the investigative team. And then if there's not a project on there you see, there's going to be an upcoming RFA that will be announced in the next couple months, in which we'll open up all of Reprieve to outside projects. And in this regard, there's a wealth of data, genetic data, all sorts of data that will be made available, including specimens and biomarkers. So there's kind of two different ways to do it. But since we all know each other now, I hope that you're welcome to call us and we could start with a chat.
And there's a comment that the Harvard CFAR Developmental Awards may be another mechanism through which to fund new work integrated into REPRIEVE. I have a question for Dr. Grinspoon. So we've now seen the results of REPRIEVE integrated into guidelines in the US, in the UK, and also in Europe. How do you anticipate the results of REPRIEVE may influence WHO guidelines, and what are the special considerations relating application of REPRIEVE findings to people living with HIV in low and middle income countries?
Yeah, that's a great question. I think there'll be a little more pushback to incorporating REPRIEVE type information in the WHO. It may get there, but from our own data, the event rates weren't that really high in sub-Saharan Africa, and we didn't have that many people, although, we did have, more than 1,000 people in sub-Saharan Africa. But so there may be other factors. It may be that we recruited very, very healthy people who were volunteering for this trial, or other factors. There may be certain genetic factors or other things. And the lower your risk of CVD, the less REPRIEVE matters to you. And the higher the risk, the more it matters to you, even though we recruited overall low to moderate groups. So I think WHO will need to grapple with that and try to figure out a way to incorporate this while also acknowledging there being maybe specific risk patterns unique to sub-Saharan Africa. But we're in discussions with them now.
Great. And one last question for Dr. Triant. Can you speak a little bit about differences between the PCE-derived risk score that's currently used in U.S. guidelines and the forthcoming PREVENT score that's being recommended? What are the implications for people with HIV with respect to this transition and the PREVENT score?
Sure, great. I will be brief because we're at the hour. So as people might be aware, the AHA released a new cardiovascular risk calculator just this year, the PREVENT equations, in 2024, with the ultimate goal of replacing the PCE equations. So the PREVENT equations differ on a number of levels from the PCE. It's a more diverse data set of over 6 million individuals, a younger starting age, so 30 versus 40, which will have implications for HIV. A new covariates in the model that reflect a cardio kidney metabolic framework, removal of race from the model, and inclusion of a social deprivation index, a broader outcome that now encompasses heart failure. And so there are now different scores for ASCVD and then separate scores for total CVD and heart failure. So I think that they'll, if there's in fact widespread clinical uptake, the implications will be important because a lot of the work we'll have to redo to assess how the PREVENT risk thresholds translate and whether that in fact underestimates risk as well for people living with HIV, and adapt statin guidelines accordingly.
Great. Thank you both so much. And thank you to the CFAR for organizing this presentation. Thanks to those who joined in the audience. We are at the top of the hour, so we're going to close now. But if there are additional questions, please definitely feel free to email us, and we'll look forward to talking with you.
Thanks, Markella. Thanks, Jean.
Thank you. Thanks.